It's my pleasure to be co-chair this session. Very important topics on microbiota. I think it's very important and very hot topic at the moment. My interest in microbiota started about 8 years ago when I was returning from England at Heathrow Airport. I bought a book by Tim Spector. I don't know how many of you know him. He is a professor in genetics and epidemiology. And the book was called Diet Myth. That is all about microbiota and food and everything. And I was so interested that I asked my colleagues at Chulalongkorn to study microbiota, but at that time, nobody was interested. But I'm glad that a lot of people in Thailand and in the region are interested, because I think this is the future, which is already here. And today it's very interesting, and I'll be interested to listen to the two authorities in this field. So I'll pass this further to my co-chair, please.
Right. Good morning, and thank you, Professor Pinit, for the introduction. I certainly agree the gut microbiota is really a game-changing area that all of us as a gastroenterologist should try to learn and be familiar with. Now, we have today two prominent speakers, but allow me to have the privilege to introduce Professor Yamaoka. In fact, he needs little introduction. He's very well known to us. I've already heard many of his previous talk, and I certainly would think this is no different, will be an excellent talk. So I'd like to welcome Professor Yamaoka on the stage and deliver the lecture. Thank you very much.
Okay, thank you very much for inviting me to talk. Today, my topic is a human gut microbiota related to GI tract disease. But usually I'm studying about H. pylori, so this time is also focusing on, especially on the gastric disease. As you can see, this graph shows the incidence and mortality of gastric cancer in the world in 2020. This is sorted by the incidence and blue color. The worst one is Mongolia, and unfortunately, the second one is Japan and Korea. However, if the incidence is sorted by the mortality, still the Mongolia is the worst one. However, fortunately, the Japan is disappeared. Where is in Japan? So if I put into the top 50 countries in the world, Japan was moved to the 37th grade. So it means that in Japan, it's a very unique country that the incidence of the gastric cancer is very high. However, mortality is very low. Probably this is because the endoscopic advancement and findings early gastric cancer, but also the eradication therapy is very pronounced. Because in 2013, the Japanese insurance covered all the H. pylori related gastritis. So that's why every year, previously 600,000 people per year are eradicated. However, after the insurance covered, 1.5 million people are eradicated each year. And accordingly, the mortality of the gastric cancer has gradually decreased. So it's really H. pylori is important. However, to become a gastric cancer, not only H. pylori virulence, but also inflammation, host, and environment. And today's topic, gastric microbiome, is also should be important. But before going to the microbiome, slightly talk about the H. pylori virulence. As you can see, this is my review paper in 2010 in Nature. There are several virulence factors, KAGE, OIP, BAWEL, and DAPE, and probably the most important is KAGE. As you can see, the H. pylori cannot go into the cell, so that's why it only to attach to the cell membranes. And then using the needles, the type 4 secretion system, the KAGE go into the cell and disturb the gastric signaling, and then some oncogene attached to the KAGE, and then cause gastric cancer. This is a current consensus. So the KRG is a KRG positive H. pylori is a toxic, and the KRG negative H. pylori is less toxic. And even within the KRG positive, the so-called East Asian type KRG is mostly in East Asia, and Western KRG is Europe and African countries. So this is one important papers from the Mongolia that I got some short certificate to the drivers, not drivers, medical license to the endoscopy. However, but interestingly in Mongolia, as you can see, the incidence and the mortality of the gastric cancer is the worst in the world. However, so-called East Asian type of KRG is only the 3%. Most of them are surprising is the Western type or even the KRG negative strains. So to tell the truth is the KRG negative strains are all from the gastritis cases. So that's why the KRG itself might be important. However, East Asian type or Western type are probably not so much important from the Mongolian studies. However, in China, Japan, Korea, usually East Asian type KRG, that's why the severe inflammation. So the high risk of gastric cancer, in contrast in Western countries, also in Mongolia, is a KRG negative or Western type. And then the West East weak or mild to moderate inflammation and low risk of cancer. This is a consensus. However, in the case of Mongolia, it's really the KRG negative and Western type. And then to tell the truth, the inflammation itself is not so severe. So even in Mongolia, it's a KRG Western type KRG, so the inflammation is not so severe and the atrophy is not so severe. However, a high risk of gastric cancer. What was this? And so that's why from this today's topic, microbiome should be important. So we focus on the microbiome. So that we also check the Mongolian peoples, we get the samples, and then get our microbiome studies using the 16S ribosome RNA. As a result, as you can see, in normal, mostly the KRG negative cases, most of the bacteria is different, and gastritis, atrophy, the blue color is H. pylori. So most of the cases, H. pylori is predominant, and then some cases are other bacteria is predominant. And then into the intestinal metaplasia, almost 50% already H. pylori disappeared, and other bacteria is become the predominant. And then really interesting in the gastric cancer cases. Again, most of the cases are KRG negative. It's almost mostly the H. pylori cannot survive in this severe situation for H. pylori. But one interesting point is this black color and pink color. Black color is Enterococcus, and Lactobacillus is also pink. This color is 5 cases are almost all bacteria in the stomach is Enterococcus, and 5 cases are Lactobacillus is predominant. So especially I'm being interested in the Enterococcus. So we try to culture this bacteria. So that's why they're using these specimens, microbiome studies, and then if the Lactobacillus is Enterococcus is the predominant cases, we try to, the first stain is really some bacteria in here, and we try to culture bacteria. And fortunately, we got our pure Enterococcus. And then using the phylogenetic tree, we found this is Enterococcus hilae. So next we would like to check about this bacteria really is toxic or not. So using the we do some cell culture system to add this bacteria, and using the cytotoxicity and also blotting for DNA damage and for single cell gel electrophoresis for DNA damage as well, and also ROS detections. And as a result, as like the H. pylori and this Enterococcus also induce gamma H2X is a marker of the DNA damage. Also using the Comet assay, again, like the H. pylori, Enterococcus also has induce DNA damage. Okay. And but somewhat different between H. pylori and the Enterococcus is in the Enterococcus and the H. pylori, direct infection is necessary. So if the H. pylori is separated by the membrane, in direct infection, the gamma gamma H2AX is not induced. However, in the case of Enterococcus hilariae, even the its membrane is separated, gamma 2AX is induced. It means some metabolite in the, so there is not, attachment is not necessary. Some producing product induce DNA damage in the case of the Enterococcus. And we try to sequence this bacteria, and there is several candidates which seems to be the virulence. However, currently this gene are from the other bacteria, none of them are previously mentioned the link of the DNA damage. So still we need more study for the function of this new bacteria. And also for the ROS assays, in the H. pylori cases, there is several peroxides, superoxide, and hydroxyl is induced in here. Its decrease means it's induced because we use a scavenger. And but Enterococcus hilariae's cases, superoxide and hydroxyl is predominant. This is we use AGS cells, and recently we established also called the GAS organoid. So we in my laboratories we do the organoid and also the 2D monolayers, and then check the irate expressions. So the little interesting is the H. pylori induce irate. This is well known to everybody. However, in this Enterococcus, even inhibit the induction of irate. So currently, still this is unpublished data that the new bacteria from the stomach, Enterococcus hilariae, might promote gastric cancer via genomic instability induction of the host cell and also the ROS-related cellular damage. And but for the it looks like the IRA8 is an induction. So and is some cooperation of the H. pylori and the Enterococcus together have the some function to induce a gastric cancer. And also we check that this kind of the microbiome is some advantage for the detection of H. pylori or not. Currently, H. pylori detection is by culture, histology, the PCR or something like this, but whether we can use this 16S ribosomal RNA amplifications using also the GANs and Mongolian samples. And then analysis is OTUs and also relative abundance array. And as a result, if we use cut off the OTU in the 1113, high concordance rate with 115 positive and 30 negative on both cases. So most of them are okay. So, but some cases are conventional method, culture, histology, or serology. So these are positive. However, the 16S ribosomal are negative, but also the some other these are negative. Negative means white color. However, it's positive in the 16S ribosomal RNA. So this white color within this range is conventional test is a negative. However, we could get 16 S ribosome RNA for H. pylori. Also, the same result in the RA. If the RA cutoff, the best cutoff value is 4.64%. However, even it's 16 S ribosome positive, however, the conventional test is a negative. However, this is not a contamination. Probably that this is some importance issues that we could detect the 16S ribosome RNA for H. pylori, even if the normal, regular conventional method is a negative. And also some other interesting reasons are this OTU and also RA is a max in the case of the atrophy, and then gradually decrease in the intestinal metaplasia. So that if we use OTF, OTU and RA values, we might also some predict the condition of the stomach. So the gastritis, but atrophy gradually is increased. So in summary, I propose using the cutoff value of 1,113 and also the 4.4 RA for the H. pylori detection in calcium causal when detected via 16S ribosomal amplicon sequence approach. So this method might be detect if the H. pylori is a low density. So that's why this method is also useful for diagnosing the H. pylori infection. And also the RA provide the information how the H. pylori can dominate as a microbiome and how species distribution change based on the disease. And then, so the next we check a similar approach in the Indonesian population. In Indonesia is somewhat interesting. In some area, the incidence of H. pylori is very low. So we have some collaboration with the Indonesian team. So they are here. Also we together to go to the many places, and also we have the multi-center study for H. pylori in the Indonesian group with H. pylori Indonesian Society and our university. And we do the endoscopy with Dr. Arisham in Indonesian University and also from the Airlangga University group. And then, as you know, in Indonesia, there is many ethnic groups, and it's interesting is H. pylori prevalence is very different among the ethnic groups. For example, in the Batak and also Timor ethnic, incidence of H. pylori is very high. However, in other ethnic, incidence of H. pylori is low. And not in this slide, however, in the Java people, only the 4% or 5% are positive. So this is very similar to the Malay people in Malaysia. So still we don't know. Maybe the yesterday we have some discussion. However, still we don't know. But in some ethnic group is very high. And then we check the microbiome in these studies. And first we found is H. pylori negative cases, there is a tremendous amount of H. pylori, but not like in Mongolia, Enterococcus is not so much predominant, so we are not sure. However, in the Mongolian cases, Enterococcus is appeared in the case of gastric cancer. But in Indonesia, we could not find cancer cases in this study, so only the positive and negative. Anyways, the variety of the bacteria in the negative cases. And in all samples, this bacteria's components is different among the different ethnic groups. However, if H. pylori negative samples, most of the these differences disappear. It means alpha diversity among all samples are significantly different among the different ethnic groups. So the suggesting ethnic group influence gastric microbiome composition in Indonesia. However, when we check the negative samples, there is no observed difference among the ethnic groups, suggesting anyway the H. pylori infection is a stronger influence. However, in the case of H. pylori negative cases, there are several bacteria here. So we are very interested in the microbiome in all over Asian countries, ASEAN countries. So the next, we also check the Thailand, Bhutan, Cambodia, Bangladesh, Myanmar, Nepal, and Vietnam. So these are collaborate with Rick and Professor Mahachai. So we went together to the Thailand, Bhutan, and Bangladesh. So in this case, is H. pylori diagnosis test is a rapid urine test, culture, histology, and immunohistochemistry, and serum anti-H. pylori antigens. And then, we pick up the all positive cases and all negative cases. So it's really the positive, really the negative. So we pick up the 30 cases by each, and in case not reach the 30 cases, so we use maximum numbers. And so then this is some OTU cases. But again, somewhat interesting in the H. pylori test negative. So the all, as you can see, the all, even the rapid urine test negative, bacteria negative, culture negative, histology negative, immunohistochemistry negative, and even serum is negative. But if using the 16S ribosomal RNA, for example, in Vietnam cases, some cases we could H. pylori OTUs in negative cases. So this is somewhat interesting. This is not contamination because we check that very carefully. And then, so for the H. pylori positive cases, again, most of the bacteria is H. pylori, and other bacteria is very few. However, H. pylori negative cases, there's many other bacteria, but in some cases, H. pylori also appeared. So the Chow index is, of course, H. pylori negative cases. There's many different kind of H. bacteria. And probably currently we think that if there are H. pylori negative cases in the convention method, however, we can detect H. pylori in this 16S ribosomal RNA. Probably one possibility is that some temporary infection is H. pylori is coming to the stomach. However, it's only the temporary and then disappeared, or it really exists in the very few amount of H. pylori. Even we call that H. pylori negative, however, might be that some H. pylori appeared. And also this is a distribution of the bacteria in the other countries. So looks like it's a very heterogeneous. However, for example, you can see in the case of Nepal is here and Bhutan is here. So it means the composition of the gastric microbiome is very different. Even the Bhutan and Myanmar is neighbored countries, but composition of the bacteria this is in the case of H. pylori negative cases. So all the bacteria is not H. pylori, most of them. And then also in black color is Cambodia and also the Thailand. So again, the Cambodia and the Thailand is a neighbored country. However, the composition are different. So in summary, the chronic H. pylori infection might disturb the normal composition of the microbiome in the stomach, and H. pylori OTU are frequently found. Even all the tests is negative for diagnosis test. So there may be some temporary infection or something like this. Still, we need a discussion. And the gastric microbiome differed among human populations. Each ethnic groups, each countries have the different kind of microbiome. Probably this is by food, or I'm not sure. Still, we need some discussion. It's still remain unknown about H. pylori negative gastritis. So there is really, especially in Indonesia, H. pylori usually is negative. However, there is a lot of gastritis. So this is why. So the other bacteria in the stomach or a very small amount of H. pylori exists in even in Indonesia. We don't know. And still, but most important is the current challenge in the H. pylori infection, the microbiome. Studies and methodology standardization is important. Each maybe group has a somewhat different kind of their methodology. Of course, especially in the stool, in the intestinal microbiome. However, even in the gastric microbiome, so this is also very important. So need to clarify environmental exposure of the H. pylori DNA in high prevalence H. infection countries, such as in Mongolia or something. Okay, so thank you very much for your attention. We usually collaborate in especially in the ASEAN countries. So we go together, many countries. So we got the samples. So in the future, also we now the COVID-19 is finished, almost finished. So we challenge to go to many places to have a survey. Thank you for your attention.
Thank you very much, Professor Yamaoka. We'll leave the question and answer to later on. Next, I would like to introduce the next speaker, which really needs no introduction, but still I have to perform my duty. Professor Ratha-korn Vilaichone graduated from Chulalongkorn with MD, PhD, and Board of Internal Medicine and Board of Gastro. And after that, he went to Baylor to stay with Professor David Graham. He is now Professor of Medicine at Thammasat University, Chief of the Center of Excellence in Digestive Disease at Thammasat, and also Assistant to the Rector of Thammasat University in Academic Affairs. And as you know, he is Secretary of the ASEAN Stomach and Microbiota Study Group of ASEAN. He has done a lot of work, good work, has written 7 textbooks and has published international journals, about 115 publications. He also has received so many international awards. I am very proud to present Professor Ratha-korn, who I believe is an authority in whatever he does, especially in the field of HP and now microbiota. Please welcome Professor Ratha-korn. Thank you.
Thank you so much, Mr. Chairman, for your kind introductions. You listened a lot for the microbiota in the basics information, and now we're going to go for the clinical treatments. My task is going to touch on the microbiota and microbiota-based therapy. So my table of contents is going to consist in the next 25 minutes. What is a gut microbiota in the clinical practice? I believe all of you is going to know very well about the FMT. We learned a lot since yesterday, and today is going to let you know more about the GMT. GMT is a gastric microbiota transplantations, and in the future, we can use a gastric juice as one of the treatments in the new chapter of treatment. Then we go to the highlight of the microbiota studies from the DDU this year. Like the other organ transplantations, how to make the FMT is better of the engraftments. We have more information about that things. And the last but least, we go to the microbiota clinics and we grab everything together in the summary part. To make long story short, as Professor Grit said to you yesterday, what is prebiotics, probiotic, and postbiotics? Prebiotic is the fuel. Probiotic is the factory. And the postbiotic is the goods or the products. It's very long story short, I think, just a very short definitions of these 3 important words. What is the fact about human gut microbiomes? Human gut microbiome consists of the 2 major phyla, the Bacteroideae and Firmicutes. And as you all know, that colon is the highest microbial density. 90% of the gut microbiomes come from 30-40 species, and most of them is going to be the anaerobics. Gut microbiota is maybe vary in difference of the organ, just like respiratory, you can have actinobacteria, you can have a Firmicutes. In the oral, you have a Firmicutes and Proteobacteria. The skin again, actinobacteria and the Bacteroides. In the guts, you have the actinobacteria, Bacteroides, and Firmicutes. And the last but not least, in the vagina, mostly going to go for the lactobacillus. What is important to change you from health to diseases? We know that the disperses can induce the immune response and stimulate the inflammation by induce the inflammatory mediators and a lot of the pro-inflammatory cytokines. And then they're going to cause a chronic tissue damage. And finally, the disease is going to develop. Low of the gut microbiota is going to have two roles. The first one is the metabolic roles. The second one is the protective roles. I have to balance between these two important roles of the gut microbiota. And the development of the gut microbiota is very important, especially in the first few years of your life. The very new study from Korea suggests that if you get a give birth by the normal labors and the cesarean section, maybe in the next future of your life, maybe change of your microbiota, and seems like normal labor is going to be better than the cesarean section. Come up a little bit for the HP and the microbiotas. I believe that Professor Yoshio Yamaoka is going to let you know very in detail of the HP and microbiotas. For the clinical treatments, when we use the regimen treatment for the HP along with the probiotics, it's going to help two things. The first one going to improve eradications in the modest effects. The second one, it can reduce the side effect during the treatments. And even the meta-analysis from the UEJs several years ago also summarized that when you treat with the probiotics, it can modest effect for the HP eradication improve, and they can reduce the side effects. Anyhow, I think this study is going to be very important. This study published in Frontiers Microbiology is 4 or 5 years back. They mentions about the association between the gut microbiota and the HP-related gastric lesions in a high-risk population of gastric cancer. So it's means that many of you is going to eradicate this bacteria. And sometime after killing the bacteria, the chance to develop the stomach cancer is still going on. And furthermore, maybe many of the patients after treatment of the HP, the symptoms still going on. That's like polymyositis. They conclude in the Cochrane analysis that if you treat the one patient with functional dyspepsia, 1 in 14 is going to be better. You leave a lot of patients there. So why it's happened? Microbiotas may be one of the explanation. After the HP treatments, the bacteroides is going to be significantly decreased, while the Firmicutes and Proteobacteria is going to significantly elevations. This is going to be related to the gastric cancer that's still going on and maybe explain why the symptoms going to be persist. And from these basic information lead to our recent publication in Frontier of Gastroenterology, and Professor Yamaoka is one of our co-author this article. We demonstrate the efficacy and safety of L. rhamnosus and L. Vilaichone as an adjuvant therapy for HP eradications, and this is a DBRCT trial. So we grabbed 100 patients with HP positive and divided into two groups. The first group to receive the probiotics. The second group received the placebo. In the probiotics group, we need another 1 month continuous the probiotic after the HP eradication and to see the results. I believe that you're going to know that after we add the probiotics, the HP eradication and the side effect is significantly improvements in the group with probiotics. But furthermore, the probiotic adding to the treatment regimens could be further reduce the GI side effect and improve the GI quality of life. So it means that maybe we treat a lot of patients with HP infections while the symptoms still going on. It might be related to the gut microbiota, and it might be wise to add a little bit more of the probiotics to reduce the symptom after the treatment. So my middle of the talk is going to go to the FMT therapies. What is a milestone? The ancient Chinese medicine. I believe that many of you here can have a Chinese blood. They used the FMT treatment of the diarrhea therapies. In 1958, the Denver Colorado to start to use the FMT in the patients with the severe pseudomonas colitis. And 2013, this is a year for FMT. Many discoveries, and the US FDA is going to have a workshop. And later on, they're going to approve for the treatments of the recurrent C. difficile infections. Until now, so I believe that many of the new indications going to bleeding explore. I believe that Dr. Justin Lee is going to know this gentleman very well. And this year, our teams went to the DDMU in Chicago. We have 2 oral presentations and 5 posters, and met my supervisor, Dr. Grams, as Professor Pinit says. Dr. Grams, the band is very strong, but right now he walks a little bit slow. So I grabbed the highlights of the DDMU this year in just only one slide for the GI. Most of the talk in the meeting gonna say about the functional GI disease, the EOE. EOE is very important. Mostly we cannot see the patients with the EOE. I believe many of you can see the eosinophilic esophagitis. Ajahn Sangdao, have you met one? I think it's very rare, but you're going to see the EOE in the examination, believe me, all right? The ARD is acid-related disease, the IBD, and the last at least, many talk to the microbiota and the FMT. They have once companies becomes a main sponsor of the DDW is named Microbiota. They're going to produce the capsule, the FMT. I'm going to let you know very soon about the product. What is the potential therapeutic target for the FMTs? Many of the neurological disease, psychiatric disease, cancer disease, autoimmune, infectious disease, cardiovascular disease, and many more in the GI tract. It's not only for the functional disease at all. Somehow we go to the hepatic encephalitis, the cirrhosis patient, and very informative data in the IBS and the IBD. And now the treatment of the FMT is going to go for the cancer prevention. What is the root of the FMTs? We're going to have many roots. The major roots are going to have 4. The number 1 is the nasogastric and nasoduodenal. The second one is a retention enema that used a lot in our clinics. The third is a colonoscopy that's supposed to be one of the best channel to deliver FMTs to the human systems that are supposed from the European data. And the last at least is encapsulation. FMT start first with the C. diff in 2013 about Paul Mayotti in Cochrane Reviews and a systematic review in Annual Internal Medicine. The response of the FMT in the C. diff is approximately 80 to 90%. That's very impressive. And the data that changed the treatment of the FMT is published in New Internal Medicine again in 2018. After this, the publications, the treatment of FMT is not only for the recurrence of the C. diff, but they go to the primary C. diff treatments. In this study, they can randomize the 20 patients with C. diff infections, half to receive oral metronidazole and another half to receive of the FMT. You can see that the response of the FMT, even not significantly data, but at least it seems like much better than the oral metro for treatment of the acute C. diff. Anyhow, treatment of MT is just like two sides of swords. You may have a very benefits, but anyhow, they can have some harmful. Professor Elizabeth Libley in Harvard Medical School, one of my good friends, they published 2 patients report with the E. coli ESBL after the oral capsule FMT. One case is the Hep C cirrhosis, another case is the MDS, and my goodness, the MDS case is dead. I just talked to Francis Chan that they done a lot of FMT in Hong Kong. It said that half of the donors in Hong Kong, they have an E. coli ESBL positive. So it's going to be very important to screen the donors and it's very cautious to use the FMT, especially in the immunocompromised host. How about our experience? A couple of years ago, we published in the American Journal of Biomed about the first case of the FMT transplantations in the treatment of the primary C. diff in ASEAN. At the time, we got the patients with acute C. diff, we have diarrhea more than 10 times. After 1 time of FMTs, we had edema, the patients respond very well. And in the next day, the patients stop the diarrhea and back home safely. So how about the FMT data that's published in Lancet Gastro last year about the FMT for the first or second C. diff infections, that means the early FMT treatment. This is a DBRCT trial. They grabbed 42 patients random to receive the FMT capsule or placebo after receiving the vancomycin. And treatment is for 10 days. This is a data from Europe, so Denmark. From the interpretations, they demonstrated that in the patients with first or second C. diff infections, first line of the FMT is highly effective and superior to the standard vancomycin in the treatment of the C. difficile infection. For summary and gap, long story short, from the data from DDW this year, they mentioned about the FMT. The efficacy to treatment the C. diff is more than 85% to prevent the recurrence, and this is going to be important. That makes the Microbiota can get a FDA approved by this indication. And superior to the antibiotics. Fresh aversion is not is pretty much the same and no difference. And it is that donor independent. It means that even donor, that's a good donors. You don't have to get a super donors for the treatment of C. diff at all. More adverse events in the come-ups, and you have to very, very carefully, and you have to need very cautious when you use in the immunocompromised host. FDA guideline for the FMT is evolving, and standard treatments are now approved for the C. difficile infection. When we come up to the mice to moderates, IBD, I believe that's in the end of today's, we're going to get a good talks about the drug monitoring by the Aqua Afif from McGill University. FMT for the IBD start in 2015, and our recent and this is a recent study published in Gut last year mentioned about the FMT along with the AIDS or special diet. By anti-inflammatory diet alone is effective to induce remissions in a mild moderate UC. This is a RCT trial. What is a diet? Diet is mean that's avoidance of the gluten, grains and margarines, and also with the processed meat. When you use along the FMT together with the special diet or the AIDS, they found that the combination of the FMT and the AIDS diet would be very effective and safe for the patients with a mild to moderate UC. For the MDR or multi-drug resistant FMT might be got more information about this indication. They first observed in feces of patients after FMT when the patients receive in the recurrent C. diff, and number of the antimicrobial resistant genes is decreased after the FMT. This is going to be the first noticed. FMT might be increased the Bacteroides and Firmicutes and reduce of the Proteobacteria. Proteobacteria, this is antibiotic resistant gene that's mostly found. FMT also transfer and produce bactericin that reduce some pathogen, especially the VRE and the CRE. When we see about the MDRO trials, they're going to start in 2017. And a very recent study about the FMT is just published in Biomedicine last year about the efficacy and safety of the MT for the clearance of MDRO under the multiple comorbidity. This is a prospective trial. They use the FMT admitted via the colonoscopy in the 48 patients, and microbiota analysis of the fecal samples going to done in 1 and 3 months. This summary that the microbiota analysis support the FMTs effective for the MDR or decolonizations by reversing of the dysbiosis. One of the indications used a lot right now is the FMT in the IBS. The start case is going to be in 1989. And our recent study of the FMT we present in DDMU last year about the effect of the FMTs on the IBS. And this is a DBRCT trial. We graft 20 patients with IBS, half to receive FMT, and another half to receive the placebo via the rectal enema. And we demonstrated that the FMT via the rectal enemas can improve the overall clinical response, the IBS, SSS, and quality of life of the patients, much better than, significantly better than the placebo. And another ones, we go to the encapsulations. We comparables the efficacy of the encapsulate FMT along with the enema FMT and the placebos. And again, encapsulated FMTs and enema is going to be greater effects than the placebo. And Dr. Nasuda is going to let you know more in detail about this study in the next session. How long we can use the treatment for the IBS? Professor Mahachai, I believe that you have many of the IBS patients, and sometimes we have to use a lot of medications and have to use daily. One interesting data from Professor Elsa, he is leader of the FMTs in Norway, and we know each other very well. He did a very good study published in Gastroenterology last year. They used 125 patients and divided into 3 groups. The first group to receive placebo, second group receive 30 grams of FMT, and other groups to receive the 45 grams of the FMT, and analyze the stool analysis along with the microbiota study. They use the MT via the distal duodenal by use the EGD. Also, he demonstrated that the FMT results in a very high response rates and long-standing effect with only few cell-limited side effects even, and the durable can up to 3 years. So it means that the good data that support the use of MT in the IBS, maybe you use just only single MT and it maybe lasts long for 3 years. So we come up to a cancer treatment. We know that the symbiosis gonna make cancer depressions. They can, another thing is the dysbiosis is make the tumor progression. The fecal microbiota transplantations is the innovations for treatment of the cancers. The FMT proposed as an excellent method and influence response of the cancer's treatment, especially for the chemotherapy and immune checkpoint inhibitors or CPIs. The programmed cell death ligands and the cytotoxic T-cell associated proteins can diminish immune response against the cancer and might be reversed by the FMT. FMTs help to promote the complete response and chemotherapies unresponse, improve the response in the refractory of the cancers. Our FMT research and study, we start first in 2018. We come together with Professor Mahachai to McMaster University, so stay with the polymyelitis and come up to MIT, and along with get a good collaborations with the Open Biomes. Many of you are going to know Open Biomes very well. Open Biome is a non-profit stool bank and used for more than 700 centers in all states of the United States. Right now, Open Biomes produce the stool 25 tons a year. And this stool is going to send out not only in the US, but also for the international. And I believe this is a huge containing of the stool that we use a lot in our practice. Our stool banks and established in 2018. We established stool bank in Thailand because we like to get a consistent in screening, testing, and processing, safety assessment. The important things about the FMT is we have a very difficult times to find donors, and believe that many of you here, if you like to be volunteers, I'm very happy to get you as fecal donors. Many of my students are going to be donors very soon. Unfortunately, from the 20 patients, we didn't get any good news, and we get another 10 patients to screen again. Some patients get E. coli, some patients get HP infections. So please, if you like to join our research, you could start first with to be a donor. Professor Chakawut, if you have one good donor, send to me, please. Stool banks in Thailand is going to ask for lower cost and provide fully test units for the emergency use. And this is going to go for our labs. It should be a BSL level 2. We have 3 freezers that can store fecal donors and fecal recipients before we go to the microbiota analysis. And this is a stool sample transportations. Many of our friends, not only in Thammasat, right? Now, some of our friends in Ramathibodi, in Sirat, use the FMT for the clinical treatment, mostly going to go for the C. diff infections that cannot respond to the medication. And last year, we got a Boston trips, again, for academic at FMT research corporations with Harvard University and MIT and Open Biomes. And this is Professor Lipley's very good friend. She just got a publication in New England Medicine for the FMT. She is the lady that report the death case in the MDS patient after the FMT encapsulation. And a lot of good friends, Professor Arm from MIT, and many good friends from Open Biomes. Our successful, we got the FMT encapsulation success a couple of years ago. When we got the fecal donors, we grabbed 50 grams of the stools, and then we go to freeze dryer with the lyophilization technique. Then we clean everything to a small pieces and make a capsule. Our capsule price, someone here like to try, is only $300 US. You know Open Biome, right? Open Biome in Boston, the price is unbelievable. Okay, Justin, if you like to get one, in my case, it's cheaper, right? In Open Biome, the cost is more than $2,000 US. So the price around 7 times different. I believe that our quality is not inferior to the Open Biomes. As I mentioned before, they have a new pharmaceutical companies or FMT companies that become one of the main sponsors in the DDMU this year. You can see a lot of people in the meetings that get very interested in companies. And these companies, Microbiota, they just get the US FDA approved in April this year. They produce the FMT pills or FMT capsules for treatment of the prevent of the C. diff infections. The capsules, they use only 4 capsules daily for 3 days. This is just published in eMedicines a couple of months ago. The name's Microbiota capsule. And my goodness, the price is $9,000 US. So in our case, $300 US. In the Open Biome is $2,000 US. And for the Microbiota is $9,000, close to $10,000 US in one treatment. So it's very, very expensive. So FMT in Thailand right now, many of my students and my GI fellows gonna go to the treatment of FMT, IBS, and Dr. Natsuda. And many of the fellows gonna go for the fatty livers. Dr. Prowse here, she's gonna do the FMT treatments along with the HP eradication for the naive case. And another doctor is going to go for the obesity and metabolic syndromes. I believe that maybe we can see some of the candidates to get in our trial. As Professor Jigmin Liu said to you yesterday, somehow right now we don't have to use the whole feces. We can use only the SIR 109 that published in New England Journal recently. The SIR 109 is the encapsulated alpha mucutis bacteria, and you use the capsules for 3 days compared to placebo. It responds very well for treatment of the C. diff infection. Another new story of the microbiota treatments, it might be go to the GMT or gastric microbiota transplantations. They first introduced these techniques from the Korea groups last year and published in Gut. The Korean group, they demonstrated gastric fluid from patients with a chronic gastritis, IM, and gastric cancer inoculated to the germ-free mice. And even the HP is negative. The gastric microbiota transplantations from the human patients induce the pre-malignant condition. And believe that somehow when we change the microbiota in the stomachs, it might be change the situation in the stomach. Even can progress to the cancer or inhibit the cancer's progression. Like the organ transplantations, we need to get a better engraftment. How to maintain a benefit after the microbiota treatment. Professor Sonnenberg from Stanford got a very great talk during the DDMU this year. Sonnenberg suggests that microbiota target diet interventions used for 17 weeks is going to be very important to maintain the engraftments. What is the dietary process? They use the fermented food such as kombucha. Everyone here drink kombucha. Just when you drink kombucha, it's maybe good for you, right? And yogurts and kimchi. Kimchi is right now it's very popular for Japanese and for Korean foods, along with high fibers. For around 4 months, it might be better after the FMTs to get a better engraftment. We don't have only brain-gut axis anymore. Now we go to the brain-gut and microbiota axis. And currently, number of the microbiota-related clinical trial by regions it pop-ups in the past couple of years. The clinical trial-related microbiota is not only in the United States, but for the whole North and South America, in the Asias, in many of the Europes, in Southeast Asia, such as Thailand, in East Asia from Professor Yamaoka teams, and also in the Pacific regions. And most of our study is going to go for the IBS and the IBD. For the C. diff infections, and the last but not least for the cancer, for the treatment and the cancer prevention. So before I go to finish my talk in the next few minutes, I think phenotypic microbiota is our future treatments of the microbiota therapies. I believe that we can change the obese ladies to be a movie star. Yeah, I believe that Thai is going to know Yaya very well. And how we can stop cancers and how we can live longer. I think specific donors may be one of the key factors. I believe that a donor is not the same. Maybe donors might be suitable for each disease, and we still need to get the super donors. In our labs, to be honest, we have only one donors. And I believe that the donors can treat very well in C. diff and IBS along with the HP eradication. And one donor, even once, I think that she might be the super donor. So my last talk in the next few slides going to touch on the microbiota clinics toward the clinical revolutions. I believe that many of the leading hospitals in the world, they go to the microbiota clinic, even in Thailand. What is the jobs for the microbiota clinics? To preventions, early detections, and quality of life of the treatments. Preventions mean that can promote health and reduce chance to develop disease, such as of many functional disease, infection, and inflammatory disease, or even cancers. It can get the early detections, reverse the microbiota dysbiosis, that's the origin cause of the problem. And Mr. Chairman, ladies and gentlemen, so my summaries. What is the microbiota treatment in 2023? Dr. Grit let you know yesterday, we have a diet modifications, we have a prebiotics, we have a probiotic, we have a postbiotics, right? We have live biotherapeutics bacteria such as the SIR 109. We have a FMT. FMT is available many in the US open biomes. Don't forget the FMT is $2,000 US. Rebiota is $9,000 US. In Thailand, $300 US. And many of the centers in Europe can produce the FMT also, along with in Hong Kong and in Singapore. And the last but not least, the newest one for the treatment of the microbiotas, we call the phage therapy. What is a phage therapy? Is the viral phage therapy or phagotherapies that they use for inhibits the pathogens bacteria. And I believe that now the NIH from the US, they grant $2.5 million to 12 centers around the world to promote the phage therapy. And right now it's in the clinical trial stage. I believe that in the next few years, phage therapy is going to be available for the clinical practice. Thank you so much indeed for your kind attention.
Thank you. Thank you very much, Professor Ratha-korn, for your wonderful talk and for the good work you're doing for mankind. We have a few minutes for questions. Anybody from the floor or from online?
Yeah, very exciting talk. There's no open question yet, but maybe allow me to ask some question. Maybe my first question goes to Ratha-korn, since you're already on the stage. Certainly, the concept of super donor is very interesting. I believe, Professor Pinit can be a super donor. He has this secret of longevity here, and he may hold some secret in the gut microbiota. So, do you have any kind of criteria to say that, okay, this is a suitable super donor? At least some of the students here who satisfy the criteria come to you.
Yes, a super donor is not the first mentioned by me. Paul Moyardi in McMaster's, they mentions about the super donors in the patients with the IBD. They get the donors number A, B, C, D for the treatment of the IBDs in McMaster's, and they found that only donor B is response. The rest of the donors, A, C, D, is not response very well. So this has come up for me for super donors. So it means that not donor is pretty much the same. And some disease can have a donor dependence and donor independence. You maybe know that in the C. diff is donor independence. Even each donor is fine if you are good donors. But in the IBD or even the IBS, maybe we need specific donors. To be a donor of the FMT is not easy like to be a blood donor. You have to pass three things that I believe that Professor Pinit passed all three. The first one, you have a good mind. You have to be a good people, because FMT is going to treat for many of psychiatric and neurologic disease. The second one, you have a good body. Your blood test is going to be very good. And the last at least one, you have to good for the GI tract, because we have to deliver your fecal donors to the recipients via the GI tract system. So when somebody have to be a donor, it's just only 3% to pass this criteria. So in our lab, we use the standard questionnaires to prove that you don't have any neurological disease or psychiatric disease. We get very extensive to test your body with the blood test and stool examination. And right now, we have to go to the GI panels to make sure that the donors can have a safe for the recipients and don't have any E. coli SBLs mentioned in the New England medicine. And the lastly, you have to very good at GI tract. Your stool should be good in quality. We have collaborations with companies that can demonstrate the microbiota analysis that we're going to know the bacteria may be good to deliver to the patients.
Okay. Oh, yes, Professor Yamaoka.
Well, very, very good presentation. And for example, in my talk, also, this is only the gastric microbiome, but it's very different in the different populations. So usually in this donor also, if you use in the Thailand, the donor should be the Thai people, or it's all universal people. So in the future, it's super donor. Even the one person can use for the all over the world. Or how do you think?
So if you come up to Open Biome, they use mostly the donors going to be the US citizens. One time, 5 years back, I went to Open Biome. I can see that a lot of people stay in front of the Open Biome clinics for the fecal donor, for the donations. They grab a little money for return, but it's not much because it is for donations. Donors from the Open Biome, they use not only in the US. Right now, they spend outside in the international, and in Singapore also, in the Hong Kong also. I think that the stool super donor doesn't mean for the nationality, because treatments might be depend on that you are a good donor or not a good donor. And the past three criteria from to be a good healthy, to good in the GI, and to good minds. But most of the labs of the FMT right now, they care only for the GI tracts and the healthy. I think that the minds to be a good donor might be important factors.
Can I have a quick question for Professor Yamaoka? I like the story of Enterococcus hirae. Now, do you have any plans to validate that in other population? Because obviously, it does have a role in probably in the non-H. pylori gastric cancer, correct? And do you have any plan to validate this finding in other populations?
So currently, this bacteria is only isolated in the Mongolian populations, and we also check in Indonesia. So it looks like some Enterococcuses appeared. However, there is not so much predominant. So that's why also it's very difficult to culture. Because in the Mongolian cases, some cases are almost all bacteria is this bacteria. So that's why we can culture. We could culture. However, in other countries, there is many different kind of bacteria. So it's very difficult to isolate. So this is also a program, but we try our best to also apply to the other country.
Can I ask the last question as time is running out to Professor Yamaoka? I'm interested in health promotion and disease prevention. And my usual advice to the population is that to eat a lot of vegetables and fruits, which is good anyway for many diseases. From the current knowledge of HP and microbiota, what do you suggest is the prevention for gastric cancer?
This is very difficult. So mostly the prevention is also difficult, but now so that's why we are thinking about for the Indonesian populations in the Java people and also the Malay people. We would like to know why they have a low prevalence of H. pylori. So maybe some food is different, or something that prevent the H. pylori infection. So currently we could not find any evidence. However, this some food or something is also might be important for the prevention.
Last words, the good bug is the dead bug.
Thank you.
I think we have to end this session now. Thank you very much, both of you. Very good talk. Thank you.